Okay, James Scott, PE, manages Health Facilities Engineering section for HFES for the state of Michigan. In his role, he oversees the approval of construction and renovation of healthcare facilities under the Public Health Code. He represented HFES on the committee that developed the minimum design standards for healthcare facilities in Michigan. He chairs the Health Facilities Planning Seminar Committee and represents the state of Michigan on the Healthcare Guidelines Revision Committee. So, welcome.
Well, thank you, John, for that fine introduction, and it's good to see everybody here. I don't see Mark in the room anymore, but this morning he made the comment about engineers being poor communicators, and so that kind of gives me an opening to use this. How do you tell an extroverted engineer from an introverted engineer? The extrovert looks at your shoes instead of his own. So, as an engineer, I'm allowed to say that. Anyway, as we look at construction and infection control, there's a couple of ways that we can look at things. One that was alluded to in some of the previous speakers was what are the impacts of actually doing construction on the healthcare environment. And I want to look at it from the other aspect of why do we construct health facilities the way we do in order to try and promote infection control within the facilities. So I want to start off with a little bit of a brief history. Yesterday, we were reminded that Ignaz Semmelweis, who was also known as the father of infection control, determined in the 1840s that hand washing was necessary before each examination in the obstetrics ward. And as Elaine Larson pointed out yesterday in one of the statistics she presented, recently only 4% of the physicians were complying with hand washing in a GYN unit. So it seems like 170 years later, we still haven't gotten the message. Shortly after Semmelweis, Joseph Lister developed the idea of using carbolic acid to treat the air in surgical environment. And so that's probably the first attempt at treating the air in an operating room. Robert Koch was instrumental in determining the theory of germ theory and the transfer of disease by germs rather than miasmas or other things through the air. And as we saw earlier this morning, Florence Nightingale was instrumental in starting to design hospital wards in 1854 during the Crimean War, when she first started using windows and opening ventilation. And later on, she created a design for hospital wards back in her home, England, that included separation of the patients to prevent transmission from bed to bed, included the use of daylighting with large windows and ventilation, and high ceilings and heating in the middle of the room to try and improve air circulation. So these are all things that have been done over the years, 150 years ago, in order to try and improve the environment for healthcare. Now, it was also mentioned this morning that in 1946, the Burton Act was passed, and that became the first major funding in the United States for the construction of healthcare facilities, specifically for hospitals. And that program was to provide either loans or grants to allow hospitals to be constructed in communities where they didn't previously exist and where there was some reason to believe that they would become viable operations after they were completed. But along with the funding came regulation. And so in 1947, the general standards of construction and equipment were developed. and those were continued under that name until 1973. In 1974, they were published by the Department of Health, Education, and Welfare and were renamed to be the Minimum Requirements of Construction and Equipment. And in 1984, HEW, or Health and Human Services, decided they were no longer going to publish regulations. So they were passed on to the American Institute of Architects, which published them as guidelines for construction from 84 to 2000. And then the Facility Guidelines Institute took over after that and now publishes them as guidelines for design and construction. Now, in Michigan, we took a look at the AIA guidelines that were published in 1992 in the year 1996 and decided that they were still a best practices document and that what we needed as a regulatory document was a minimum standard. So we spent 3 years, and I spent 3 years of my life developing the 1998 minimum requirements or minimum design standards for healthcare facilities in Michigan. And as a result of that and my interaction with the now departed Judine Bartley, who was a wonderful mentor in infection control, I was asked to become a member of the Health Guidelines Revision Committee for after the 2001 document was created. In 2007, we updated the minimum design standards in Michigan, and those have been adopted by the state legislature as law. A couple of the things that we look at as we looked at the design standards were room capacity, room configuration, hand washing facilities, windows, details, and finishes. In the issues of room capacity, we started out with, in the older standards, going from the wards that Florence Nightingale had looked at to 4 bedrooms. And those were acceptable up through 1987. At that time, the standards were changed to require new construction to be semi-private rooms or private rooms. And in the guidelines in 2006, they were updated to require all private rooms in new construction. Michigan still allows semi-private rooms in the 2007 design standards. But when we look at room configuration in those rooms, one of the big things that was put into place was a requirement that there be 3 feet of separation between beds. And as we saw earlier in one of Russ's slides, the spread of droplets from sneezing and other sorts of things is generally thought to end at about 1 meter or 3 feet. And so that was the rationale primarily for providing that spacing between beds. Another thing that we took in 1997 and also in 98 and 2007 as very important was providing hand washing. And as we heard yesterday, that is still a critical concern. So we actually spent 2 pages of the design standards defining all of the information you need about hand washing sinks, where they should be, how close they should be to patient care areas, what the basin size should be, how the faucet should be constructed, how much space there is between the faucet and the bottom of sink so you can wash your hands without getting them contaminated. And even looking at what is the countertop constructed of so that when all the water is splashed on it, it doesn't deteriorate. Also included requirements to provide separation between hand wash facilities and other items or other areas that should remain clean of at least 3 feet to try and minimize the splash that we saw in a slide earlier this morning. As far as windows go, we looked at requiring openable windows, and that is still or has long been a requirement for a fire safety standpoint. That was in the last few years dropped from fire safety requirements. So you're no longer allowed to are required to have openable windows if you provide mechanical ventilation in the room. Though in looking at a couple of the previous presentations, we might be better off opening the windows than relying on mechanical ventilation. And if you do have openable windows, you're required to have insect screens and to make provisions to keep people from falling out of the windows or from using the window as a means of escaping from the facility. Dr. Scanlon did mention the clinical benefits of having windows and being able to see the outside. So our requirements for windows do include a clear vision distance of at least 20 feet from the windows, so that you aren't looking at a brick wall immediately outside your window. At least you can get a little bit of daylight. So we're trying to pick up some of those clinical issues as well. As far as details and finishes, we looked at things about how equipment is installed and furniture is installed. And so things that can't be readily moved to be cleaned around and behind, we've required them to be permanently mounted. And I believe that Kelly mentioned yesterday the casework or the cabinets that had dust collection on top of them. We have required anything more than 68 inches tall, which is about here, to either have a slope top or a soffit on it to prevent that accumulation of dust, or to at least make it visible so that you can see that it needs to be cleaned. So all of those things have been incorporated as a way to improve the infection prevention and infection control. Also looking at finishes being washable and cleanable, and those around water sources like sinks and toilets to be water resistant. One of the downsides, as we've looked at requiring hand wash sinks everywhere, to be able to provide hand washing without having to go through a door to get to it, and to provide it convenient where it's readily visible to the caregivers, so that hopefully they'll stop and wash their hands on the way out of the room or in the way into the room. Unfortunately, as we've created more and more fixtures, that also creates the possibility of having additional unused fixtures and dead-end legs that could potentially cause areas of development for Legionella. We've looked at recirculating systems, and we have those in most healthcare facilities that were constructed years ago, because we have maximum requirements of temperature of 120 degrees at any sink that may be used by a person. And so that is prime temperature, again, for development and growth of Legionella in the hot water system. That may be a little bit tempered by the requirements for mixing valves that are now in the plumbing code, but the difficulty is when you've got a whole building that's got a recirculating system at 120 degrees and you add one sink, the mixing valve won't work. And nobody's going to go back in and replace 100 rooms worth of hand wash sinks so that they can put mixing valves in every one of them. But in the future, that may be an area to address, to be able to provide higher temperature water, something along the 50 or 60 degrees centigrade that was alluded to earlier today. In heating and ventilation, we need to look at bringing the facility into operation to make sure that what was designed and what was put on paper is what is actually there, to maintain those pressure relationships that Andy talked about earlier. To make sure that outdoor air requirements are meant to bring in that dilution factor. And the other important thing is to make sure that those outdoor air intakes are located far enough away from things that you aren't bringing in diesel fumes from the loading dock or any other sources of contamination from the areas around you. Another issue of concern is the use of energy recovery systems, where there may be cross-contamination or cross-connection between exhaust and supply. And so we have actually developed specific guidelines for Michigan as to how the energy recovery systems need to be constructed in order to minimize that possibility. Andy also talked a lot about filtration earlier and the need to make sure that all the filters are sealed in place. And the other thing that can happen in HVAC, and a study was published in ASHE in 2014 that showed that there was actually some significant benefit with using UV germicidal irradiation on the heating and cooling coils in the air handling system, and that it did result in a significant reduction in colony-forming units in the hospital in a study of 13 hospitals. With that, I'd like to kind of wrap things up and say, in our discussion breakout session yesterday, there was some discussion about, well, couldn't we have a code that would require that? And then that would make it easier for us as an industry to convince our management that we needed to do something. But I would caution you as a code enforcement official to be careful what you ask for, because once the codes are into effect, they're there forever. And you may get stuck with some things that you don't really want. Heard earlier today also that engineered solutions are the best way to go, where you don't have to rely on people to do something. So we try and build into the building all those things that we can to improve infection control. Hand washing with soap and water is still the most important, and especially when we're dealing with C. diff. And so we're still going to push for hand wash sinks. And lastly, as we've seen research coming out of the FGI, it appears that their decision to go to private rooms instead of semi-private rooms was probably a good one, and that the benefits far outweigh the cost. So with that, I'd like to thank you for your attention, and I'll turn it over to the next speaker.
Thank you, James. I'd like to call Kristen Vandelzen, who is an infection prevention and epidemiology project manager at the University of Michigan Health System. Kristen is a project managing the Michigan Medicine Water Management Team with subgroups in water testing, plumbing, HVAC, equipment, and patient risk. So welcome.
Thanks, everybody. I'm really happy to be here. Thank you. This distinguished panel and everyone else is here. So I don't want to talk a lot about stuff you've already heard, because we had really great setups for all of our talks earlier today and yesterday. So a lot of this has been covered, but I do want to talk from an infection preventionist perspective about some of the patient infections that occur related to construction activity, and also design from our perspective too. So we've heard lots of good pointers already, but I'm going to talk a little bit about U of M's experience. And that's not University of Minnesota or University of Maryland. It's Michigan. Sorry. Thanks. There's other U of M's, I'm sure, too. But so, of course, baseline is we're going to create an ICRA, Infection Control Risk Assessment, to share with contractors. That's pretty standard. It's been done for many years. One thing we're doing at U of M that's new is we're going to require ICRA training for all contractors and foremen on site. So they have to go through a formal ICRA training, not done by us, because we don't have the time to do all of that. We have we have other things to take care of. But they're going to have a formal ICRA training before they can even bid on a project. So that's a kind of new thing, I think. And I don't know too many people that are doing that. Example is the Carpenters International Training Fund. It's a free online thing. If you haven't checked this out, check it out. It's really pretty good. And I think it will give us a baseline knowledge that our people bidding on our projects have some understanding of what they're getting into when they come work in the healthcare system. And I think that's an important thing too. It's come a long way. We've had gone from like 20 years ago where contractors were like, I'm not going to listen to you. And now they're like, okay, what do you want us to do? Most of the time. We also are going to require maybe this is a newly coined term, require interim infection control measures. Have you guys heard of that term before? Maybe, yeah? Yay, okay, we're not as original as we thought. But It's new for us. And so what we're going to do is require the contractors to fill out these forms very specific to the project as a part of what they're doing. So this is an example of our form that is in kind of the draft phase. But we want to know exactly for the project where they're going to put the HEPA filters. How are they going to create negative pressure? There's lots of ways to do that. How are they going to do it? Where are they going to have airflow patterns created within the construction site? Are they going to need to isolate the HVAC, the plumbing? What do they need to do with that? And also, is it a multi-phase project? Do they need to have multiple different IICMs for each phase? Probably. And then also, what are their barriers? That's an obvious one. Like how and where, right on the construction drawings, are they going to put the barriers? Have you guys ever, those of you that are infection preventionists, gone in and said, oh, I thought the barriers were going to be here. And when you get to the site, they're in a totally different spot, maybe a really bad spot where carts are going to crash into them and things like that. So that's an important piece that we haven't always been super good about doing ahead of time. So we're going to make sure they have this ahead prior to construction. So this checklist is going to be very specific for the project and even for the phase of construction. Hopefully it'll help us all be on the same page. So now I want to talk a little bit about some of the infections related to construction activities. And I realized as I was listening to all the other speakers, I forgot a few important organisms on here, but I'll talk about them. So of course, Aspergillus is one of the main issues with construction activity. It is, the biggest pathogen as far as molds go related to construction activity. Some of the control measures in the literature for outbreaks have been dust control and filtration of the outdoor air. Pretty straightforward. They do cause lung, skin, and eye infections as a typical site. Of course, we want to mention Legionella, Aspergillus, other molds, and I forgot Mycobacterium in here related to lung infections, especially related to disruption of water and plumbing systems during construction. Very important piece that I think is obviously becoming a much more hot topic. One of the things they've done as control measures for these is temperature control, flushing, which I think is a really big underutilized one, chemical and other disinfection. So, for example, flushing often happens after you have a disruption during construction, but does it happen prior to building opening? So, for example, we built a more million square foot building a few years ago, really big as far as walking distances and things like that. We realized that the most of the plumbing had been stagnant for about a month prior to patient move-in. And maintenance told us they did not have time to go around and flush all those fixtures. So guess who did it? And all of my team. Luckily, we have a big enough team that we managed it. I think we flushed every toilet and every sink. I don't know about the showers, though. I don't know if we did the showers. Oops. So this self-flushing thing is the self-flushing sink. I like that. How much is it? Sorry. Okay, we will. So talking about planning for new construction, so we're planning to build a new inpatient tower. All of these topics are really relevant to thinking about design and planning for the future. And we had a lecture earlier talking about upstream planning. Thank you. I think that's a really good point. Do we think about the best practice, not just the minimum standards, which thank God we have the minimum standards, because I can't tell you how many times I've used those to say, yes, you must put a sink right there. And I still am doing it still. But I have to also say, I will say in a minute, we appreciate our facilities planning people a lot. So another type of infection, Pseudomonas, Stenotrophomonas, Acinetobacter, the list goes on and on and on. Enterobacter, probably other things that can survive in water. They can cause lung, wound, bloodstream infections. Issues are often after the design is in place and the place is built. Contaminated plumbing, aerators, faucets themselves. Have you ever seen slime dripping out of a faucet in a patient room? I have. Not supposed to happen. And these are faucets that are used. How does this happen? Somebody please tell me. I would love to have an understanding of how we could prevent this from happening in a heavily used faucet. So, sorry, I'm airing dirty laundry. But we also want to prevent splashing. So we had a few lectures on that, and I'm going to talk a little more about that because that's one of my passions is preventing splashing around sinks. So first of all, move sinks away from the patient bed. We want to talk about that. Don't have them so close that you're like breathing down the patient's neck as you're washing your hands, because we know what's in the drains. Yeah, we don't want that. Remove aerators. Most of the time you don't need them. Use laminar flow if you can, or maybe even better designs that are out there for faucets. Offset the drain. That's an easy one that I was really happy to have all of our engineers say, sure, we can do that. So that's one of our standards. So this is one of my favorite outbreak studies, Hoda et al. Really simple and elegant, where they took a fluorescent marker, put it in the drain. How many know this study? Probably a lot of people do. They put a fluorescent marker in the drain, had someone wash their hands, turned off the lights. How far did the droplets go? Too far, like 3 meters. 1 meter. Sorry, better not say it wrong. 1 meter away from the sink. That's like 3 feet. Sorry, I meant feet. But that's pretty far. What is within that 1 meter radius? If you think about it, in a busy ICU room, lots of things, including things like the next patient's dressing setup, or their respiratory care equipment, or their nebulizer, or I guess all of those things could be stored within that 1 meter radius. And where else are you going to put it? In some of our smaller patient rooms. So very important. Various attempts to disinfect the drains. They had a really hard time. They actually removed the sinks. We don't want to have to remove every sink. So we really need to know how we can really effectively disinfect these in place and come up with new products to disinfect and or heat treat in the same time. So they had to really prevent splashing. And I'm going to talk a few, actually, I think before 2009, we put into our design standards that we wanted side splashes. So design is very important. So we require in our U of M guidelines side splashes, splash guards around all of our sinks that have any cabinetry next to them. I think that's a great idea. Also thinking about what's under your sink. Do you want to be able to see if there's a leak? So this is a picture of some of our various plumbing haphazards that we've had. A sink cabinet was around the right-hand side one that nobody looked into for many years, probably, except every once in a bit. Lots of low-level leaks leading to potential mold growth under them. Also, cabinets around toilets. How many of you have a cabinet around your toilet at home? Who does that? I'm sorry, who does that? Really? You know that they overflow, they leak. So don't put a wood cabinet by them. So what we've talked about is thinking about things like, how do you detect leaks? Moisture sensors. Don't use electronic eye faucets. We've talked about that. Reduce splashing whenever you can. Laminar flow design. And flush your fixtures. How frequent should we be flushing our fixtures? What is the optimal flushing frequency? I don't know. I really don't know. I would love to know. Is it every day? Is it once a week? Probably not. So another really quickly thing that we've done at U of M is create healthcare minimum expectations for U of M. And we really wanted to demonstrate these. And this has saved us in many instances from having things built that really did not meet our expectations. And thank you to our facilities planning and design group for assisting us. We've had great partnerships with our architects to create these. And I'm going to show you just one picture of them. So this is based off ASHRAE 170, but we've tried to create something based on our procedure rooms. And then based on these 1 through 8 categories, we have a whole slew of things that we wanted to show, things like electrical, space of the room, whether a sink should be in it, all of those things. So we've created this. And so this is given to our architects and planners to use as minimum design guidelines for U of M. So I'm out of time. I wanted to talk a little bit about infections, but we do know that Pseudomonas is a really important infection related to water sources. We spend a lot of time on preventing construction infections, Aspergillus mold, which are very important and very deadly. We don't spend nearly as much time preventing Pseudomonas aeruginosa pneumonias in the healthcare setting. So I want to think about that and that risk benefit of those things. And I wanted to say thank you, NSF and Chris. Oh my gosh, this has been a great conference. Don't you guys think? Yeah, I mean, this has been great.
Okay, thank you very much. Okay, I'd like to ask Andrew Streifel to come up for a return engagement at the podium.
I'm back again. Wait, is this working? Yeah, you can hear me. So I get to talk about monitoring. What do you get what you pay for? And that's one of the things that we learned very early on is we didn't get what we were paying for. And from my experience in getting to evaluate facilities, a lot of other people didn't get what they paid for. So what we really need to pay attention to is as I stated before, the interpretation guidelines, the analysis that we need, the baseline information. What is baseline, especially for air quality? People always want a number. They want a number, and in reality, it's a rate of reduction. For example, if you have a 90% efficient filter and you have 200,000 particles outside, what should you expect to see inside? 20,000? Yeah, that 90% reduction of the 0.5 micron size particle. We don't use the 0.3 micron size particle simply because that's the most difficult particle to capture, as you saw on a slide earlier today. So we really want to be able to demonstrate that because that is the baseline information that we can compare to. I had an infection prevention nurse say to me, called me up and said, hey, I just shut down the OBGYN where they do C-sections operating room and because there were too many particles. I said, hey, how many particles did you see? Oh, there were 200,000, 0.5 and larger. You learned very well. And I say, wait a minute, that's really high. What could that possibly be? What was going on outside? Oh, there was a forest fire about 10 miles away. So again, the reality check there is if I like HEPA filters just simply because it's a terminal filter and you can expect zero. So it's a lot easier to deal with that, but yet the standard does not say that's a minimum. We put it in all our operating rooms simply because we have a high load of immune-compromised hosts in our facility, and we need that for that protection. So that was built into our design from the get-go. Of course, we want to look at the epidemiology, where's the source of the disease, and then validation of the controls. That's really a factor of existing conditions. What are your existing conditions? Because what we do when we sample, we compare everything back to our commissioning. What did we get in commissioning? What was that baseline information at the very beginning? As you saw on a previous slide that I presented, this is what the building owner's requirement states from an infection prevention parameter. So we want to make sure we have something to compare back to, because the filters get changed, they don't install them properly. And generally speaking, by the way, it's not the filter that's the problem, it's the housing. It's the housing. Those connections fail. It's the housing that has gaps in it because they bought a different filter that was never intended to be used for that type of filter housing. So we have to be very careful. And again, that leads us again back to the epidemiology. What is the source of infection? And I believe I stated that I worked on a situation where an individual got an infection and they had bypass on the filters, wherein they are negligent in the management of those filters. So there is not a standard for testing filters in place. I do it. I know how to do it because of industrial hygiene principles. But in reality, there is not an existing standard for that particular analysis. That's why we use particle counters. Particle counters are real time. If you have to wait a week or 2 weeks for your infectious particles to be cultured and grow out, what are you going to do if you find a good cluster of infection, Aspergillus fumigatus in the air? There are 100 organisms. What do? Do you treat all those patients with antibiotic? No. And that's a risk unto itself with dealing with some of the side effects associated with the antimicrobials that we use for fungal infections. So it's really up to us to make sure that we prevent by having proper installation and routine analysis of that environment so that we can say, hey, it's working. We can rule out the ventilation system as being the potential source, and that requires pressure testing, air change rate analysis. And the guy standing there with the hood doing that analysis is not creating a pressure measurement, a pressure number. He's creating the conditions to cause pressure to work for us by balancing and developing the offset, the difference between the supply and exhaust. And really, for a long time, that was very insipid. It wasn't enough to create the pressures, especially if the vessel leaked. So those were all things that are part of our design in that management. This is a hospital, an Ebola unit. They call it a high-level isolation unit. In another part of the world, they are developing pressure relationships that are quite complex. I do not have any confidence in anybody in these United States, except those that do the BSL-3 type of construction, that could do something like this. Why? Because they don't seal the rooms. We have to arm wrestle with our contractors because what? It costs more. The reality is it's money. Pay me now, pay me later. That's something that we have to really realize as part of our environment of care. You're going to do it right the first time, and if the CEO or the C-suite are mostly interested in hospitality industry and not hospital industry, what have you got? So when you develop a specification that looks like this, you've really got to have a design team and a way of actually accomplishing this particular task. When we look at pressure, we want to see evidence of control. And in this case, you can see that a plastic is bowed in, very obvious. You can take a pressure gauge, a very sensitive pressure gauge, and a particle counter to do that kind of analysis also. But really, it's the pressure that we're interested in because that is the control of the aerosol. That is moving the aerosol in the direction that we want, regardless if it's patient-generated or if we're pounding on a sink that's moldy in an effort to remediate it in a hospital setting. So it's very important that we know where to test and how to test and what we're really looking for. And the minimum standard is 2.5 pascals or 1/100 of an inch. That's really what we see when dealing with that. And when you look at the data pressure interpretation, you need to look at that baseline before, during, and after. What generally happens is they move a balancing damper to cut back on the supply air and maintain the return exhaust in the same location. But where do you balance it back to? You should mark the duct. How many people think of that? We've trained our air balance people. We've trained the sheet metal workers in our facility to be able to do that sort of thing. But then what is the intensity that we want? We say we want a pressure differential of 1/100 of an inch. But what is that? 1/100 of an inch means the air is moving at about 400 linear feet per minute underneath the door. If it were 1,000th of an inch, it would be about 100 linear feet per minute. There's a big difference in your ability to walk 100 yards or 400 feet versus 100 feet in a minute. So again, we're really looking at the speed at which it moves, and we do not want to go to 1/10 of an inch. Why? Because then the air starts to move at about 1,300 feet per minute. When do you start getting wind whistle? About 900 feet per minute. So you don't want to trade control with a nuisance. And the nuisance is wind whistle. We had a lot of whistling in bone marrow transplant rooms when we didn't know how to deal with that. So again, we need to make sure that we understand that clean the dirty airflow principle, because that is really a critical part of managing that aerosol. So interpretation of data with respect to particles and construction, we really want to see a % reduction, as we stated. And the particle size that's most often associated with construction aerosols is 1 to 5. 1 to 5 microns. I did a lot of analysis on seismic reconditioning in California, as well as hospitals, people in this room, where they were doing blasting, for example, to make room for some radiology equipment. And we set that 1 to 5 micron because we've seen that so often in the past as an indicator of an aerosol gone wild in a critical environment. So again, local controls, again, are really important. Know the aerosol that's generated. If you're working in an environment where they're doing a poured floor, you have volatile organic chemicals coming off. That is a vapor that is countable with a particle counter. So we have to know what we're looking at, what we're seeing in an effort to make sure we get it right. Wait 2 days and that vapor will go away because it has evaporated. Ventilation management is important to get the air out or recirculate it. We created a booklet some years ago for bioterrorism that's apropos for construction management because it uses the same principles to isolate. Air sampling is not that easy to do. It's a penny short and a day late. That's why we like the real-time analysis. There are a variety of air sampling equipment. The one on the right, your right, was one that we used. It's a high-volume sampler. It samples 700 liters of air per minute. And we demonstrated at Johns Hopkins in a 1997 article by Theo that they were totally undersampling the environment. They sampled such a low volume that they were not picking up the 1 and 2 colony forming units of Aspergillus flavus that was plaguing their population. So we do have to make sure we know how to sample and how to analyze that data as part of the process. So interpretation of owner's acceptance, the air quality validation really applies to those areas where the patients are most susceptible. We want a clean, cleaner, cleanest. You just should expect the lowest counts in the areas with the best ventilation. That's air changes, pressure, and filtration. And we really need to be aware of what water quality validation, which is a work in progress, as we know. And it really revolves, again, around that severely compromised patients. If we knew what we were putting in our mouths, we'd be shocked. If you knew what you were breathing when you step outside the door here, we'd all be shocked because the body is a hero. So it's up to us to stay healthy, but yet we can't do that for our whole lives, and something's going to eat us someday. So again, drinking water standard, keep it less than 1. I made him a typo on the bottom one. That's less than 500 colony forming units of the various kinds of microorganisms that you can find. And certainly the absence of Legionella is a blessing, but yet we realize that 60-some% of natural waters that we sample contain Legionella of one form or another. So what I'm curious about is if we find Legionella pneumophila 2, we will react. But what about all the other species? Do we react? Do we shut down our towers? Do we jeopardize cooling in the building if we have Bosmani or some other kind of weird Legionella in the space that rarely causes infection? So those are some of the dilemmas that we're facing in our water management plan and the 70-some towers that we have on campus at the university where we're very closely monitoring. If we agree to monitor for Legionella, when will we truly shut down the unit and clean it? So with that, I'm finished with this presentation, and I appreciate the opportunity to be here today and yesterday.
I have a question. So your panel and the panel before you both did an amazing job. But what I'm trying to understand is, so there's a disconnect, but yet a connection between infection control and facilities management. And so do you guys have ideas on how, what is that disconnect? How disconnected is it? What are some suggestions or ways that we can bridge that gap?
I think at U of M, we've been really lucky because we had a really great facilities planning and design team. The times where we conflict are difficult, and usually they are related to value engineering. Do you guys know what that is? Yeah. So sometimes we will have our best laid plans. We will have design standards that are really, I think, really good, really focus on patient safety. And then we'll find out that someone decided that we're not going to do that. So that's out of there. And that's a real problem. And then usually we have the support of our facilities architects. It's usually made through administration is when that happens. So having buy-in from clinical leaders that understand the patient risk, and especially, I mean, it seems for us to be our medical staff, having buy-in from some key players there has been really helpful for us.
I think one of the things that's really helped us on a state level is we've always had support since I've been there in learning about infection control and been given the opportunity to meet with the Michigan Society for Infection Prevention and Control and attend their conferences, and really been supported in learning that end of the business along with the construction and regulatory piece. So my staff have a good appreciation of the needs for infection control, and I think that allows us to bring that into the discussion with the architects and engineers and with the facility operations and maintenance people as we're trying to regulate the buildings.
ASHI and the Joint Commission have been extremely helpful in this issue. I find it really remarkable that occasionally, about once a year, we get this call from some institution somewhere and says, can you come out and give us a training program? And when I finally get there, they tell me that the Joint Commission had come through and saw a deficiency in their training, the analysis on the environment of care issues, especially related to infection control systems. They would need to have training, and they have 30 days or 60 days to get it. So it's becoming, the momentum is increasing. The programs we've been on faculty with ASHI for the last 15, 20 years, and we did our own programs before that. That momentum has really, really been helpful. And the leadership at ASHI has been really, really helpful. So the C-suite needs help.
I want to compliment all of you. It's when you see folks like yourselves who are highly informed and educated, not every facilities management has that level of sophistication, as you know. And I was complimenting your colleague from the other panel. So a lot of times you step into a situation and there's a very uninformed owner all the way from the C-suite down to the facilities management. So I really appreciate your expertise. And I think what's interesting in how you describe things is the practicality of how it gets to the field. And that's not always an easy thing to do in translating the code from the drawing to what's expected to what's the costs are. And there's a lot of subtleties to that science doesn't always fill in that gap. And so I think as we move forward with the HITs, we need to keep that in mind, that those gaps are going to continue. And I just wanted to make one comment. If you are going to, maybe U of M is doing this, if you are going to do training and looking at infection control, I would recommend your contracts include the reference to those documents in your general conditions of the contract for the professionals. If you don't do that, you're not closing the loop that if the accident does happen, it was on their system that they were participating with the team, and a lot of owners don't include those in their general conditions of the contract. So that's something for the audience to keep in mind.
One of the things that happens is there's an RFP put out for whatever we're trying to build, and that request for proposal is contingent on them reading our master spec. Because we have a section of infection control that says you shall have trained employees, you shall keep the rock off the slab, you shall follow SMACNA rules for ductwork installation. That helps hugely, because then they're bidding on something and they're not saying, didn't intend to do that up front.
Yep. Yeah, ours have them in the bid documents. Unfortunately, it's about 150 pages, and I'm not sure who reads through them, but we have contractors that we use and we have contractors we don't use because we found out they don't read them. So we don't use those ones anymore.
Thank you very much, panel. Excellent. A couple of comments here. On moving away again from prescriptive standards and guidelines, et cetera, ways of doing things, to performance-based with validated measurement. And if we can have our standards and guidelines written in an objectives-based format, so you have a prescriptive style the way they're written now, and then state the safety objectives we're trying to achieve, and then allow alternate solutions and innovations that would accomplish those, I think that could help implement improvements a little quicker. And some basic challenges that I'll just leave with you. So, for example, from our sinks, why are we dispensing untreated water? So do we take out sinks? No, we don't want to take out sinks. Do we move them away from the patient or the bedside? We don't actually want to do that. They should be there, but they're unsafe to do so with untreated water. If things are important to monitor or sample on an intermittent basis, like particles, for example, they're important enough to continuously monitor. And technology is there and available to do so right now. So why would we not continuously monitor relative humidity, pressure, particles that we've all talked about in the last 2 days? And I would submit chemicals and biologicals in addition to that. And then I guess the last thing would be, why would we put bathroom fans up in the ceiling when we flush the toilet and get an aerosol, and now we just help lift it up?
I agree with that. One of the things, too, that you have to be so careful about particle monitoring in hospitals, there are 30 chemicals today that we utilize as respiratory inhalation type things. Albuterol, ribavirin, there are a whole bunch of them. And if you're standing, and I've done this, I've sampled this room, 600 particles per cubic foot, 200 particles per cubic foot, 2.5 million particles per cubic foot. Wait a minute. I got to take a deep breath here because I got to go back and look again. Oh, yeah, they're there. So you wait till the nurse comes out, and of course they say, oh, yeah, that patient's on albuterol. So we have to be careful about how we react. You can't react based on one sample. You have to be able to know the sequence. For example, if I find 2 million particles in my breathing zone, I'd go up into the diffuser and make sure that that diffuser was delivering good, clean air so that I could say, yeah, that was locally generated. So it's a matter of doing that, and that's what we did at Johns Hopkins. They were delivering 1 million particles to the room. They had HEPA filters, but the outside was so polluted that it was hard to interpret until we found the building was under negative pressure and sucking from outside. So again, we have to be careful how we interpret, and the interpretation isn't quite as simple as I tried to portray.
Okay, we'd like to thank our panel again for a great discussion.